So, good afternoon, class. Today we'll go to another topic called as Lichen Planus, which is one of the common presentations in your day-to-day OPD practice, as well as in the emergencies sometimes. This is, first of all, you need to know that Lichen Planus is falls under papillosquamous disorders, as you're only in your MBBS, so we do not go you into the detailing of these broad headings, but these conditions like Lichen Planus, psoriasis, and pityriasis rosea, these all fall under your papillosquamous disorders. Likewise, the other condition, there are other broad headings like eczemas, and then infections, which we have already covered, infections and infestations. Then later comes cutaneous malignancies, cutaneous tuberculosis, and then one class will be on immunobullous disorders. So you should first know what broad heading these topics fall into, and Lichen planus falls into a papillosquamous disorder of the skin. So by the name, you can come up that there is presence of papules, and there is squamous differentiation in the histology. So, and also these are scaly conditions of the skin. So Lichen planus, it is a chronic. Once it comes and goes. Along with the treatment. It is a chronic inflammatory skin condition which affects the skin and mucosal surfaces. It affects 1 in 100 people worldwide, and it mostly affects adults over the age of 40 years. And about half of those affected have isolated oral Lichen planus, that is without any cutaneous features. So it is more common in women than in men. About 10% have Lichen planus of the nails, and female to male affection is around 3:2, and it is very less seen in case of children. So what are the clinical types? Those are cutaneous Lichen planus, mucosal Lichen planus, Lichen planopilaris, Lichen planus of the nails, Lichen planus pigmentosus, and lichenoid drug eruption, which mimics the lichenoid eruption. So the etiopathogenesis is, I've just summarized the points. It is a T-cell mediated autoimmune disorder, which has been highlighted over here, in which the inflammatory cells attack an unknown protein within the skin and mucosal keratinocytes. Contributing factors to Lichen planus includes genetic predisposition, that is among the first and second degree relatives. Then physical and emotional stress will contribute to the affection. Injury to the skin also acts as a promoting event. So Lichen planus or the lesions are common or often when the skin has been scratched or traumatized, can be after physical trauma or even after surgeries. So this is known as isomorphic response or Cobner's phenomena. So also, the systemic viral infections are sometimes believed to play a part, in which hepatitis C is more commonly recognized, which might modify self-antigens on the surface of basal keratinocytes. Also, contact allergies such as to metal fillings in oral Lichen planus are the rare causative factor. So drugs which can cause a lichenoid rash in case of lichenoid drug eruption are gold, quinine, quinitin. So cutaneous Lichen planus, the symptoms can range from none, that is very uncommon, to intense itching. So intense itching is one prominent feature of Lichen planus, which actually is a very important feature which separates or distinguishes it from psoriasis. So there are papules and polygonal plaques which are shiny, flat-topped, and they are very common palpation. The plaques are crossed by fine white lines called as Bickham stria. Hypertrophic Lichen planus can be scaly. In case of atrophic Lichen planus, there is an atrophic center in between. Bullous Lichen planus is very rare, where bulla formation is seen in the center. So the size of the papules ranges from pinpoint to larger than a centimeter. Distribution may be scattered, it can be dispersed, it can be clustered in a single area, it can be annular, it can go along linearly, wherever it can occur at sites when there is a linear trauma, then a line can form a papules. It can be actinic, it can be annular. Actinic is on the sun exposed sites like face, neck, and back of the hands. Location can be anywhere, but most often it is present over the front of the wrist, lower back, and ankles. And the color depends mostly on the patient's skin type. New papules and plaques often have a purple or violet hue, except for on the palms and soles where they are yellowish brown, but mostly they are purplish or violaceous. Plaques generally resolve after some months to leave grayish brown post-inflammatory macules, which may take a longer time to fade in about a year or even more. So you should know these 5 P's of lichen planus, and those are papules, purple or violaceous, plain top, pruritic, and polygonal. So coming to oral lichen planus, the mouth is often the only affected area, that is on the half of the lichen planus reported cases. Oral LP could be the only presenting feature. It generally involves the insides of the cheeks and sides of the tongue. Gums and lips may also be involved. The most common patterns are painless, where whitish streaks in a lacy or fawn-like pattern inside the cheeks. And this can be the isolated presentation, or sometimes the patient can present with, this is called as, the first type is known as reticulate type of oral lichen planus. The second very common is erosive lichen planus, where painful and persistent erosions and ulcers are present in and around the cheek, sides of the tongue, and palatal mucosa. The other type is desquamative gingivitis, where there is diffuse redness and peeling of the gums, or there can be localized inflammation of the gums, could be a single feature in case of lichen planus. And when done a biopsy, it proves to come so. So the other type of mucosal LP is vulval lichen planus. It may affect labia minora and vaginal introitus. There are painless whitish streaks in a lacy or fern-like pattern. The painful and persistent erosions and ulcers can be present in the vagina, leading to erosive condition. Scarring in a later date can result in adhesions, resorption of labia minora, and introitus stenosis. So painful desquamative vaginitis preventing intercourse with dyspareunia and causing vaginal discharge can be a presenting symptoms in some patients. And the eroded vagina is very fragile and can bleed very easily on contact. So sometimes lichen planus can overlap with vulval LS, that is lichen sclerosus, which is an inflammatory skin disorder that is most commonly affecting the women above 50 years. And this is a condition which has a highly malignant potential. And sometimes just to differentiate in between these two, biopsy is a must. So penile LP usually presents with classical papules in a ring around the glands. Their white streaks and erosive lichen planus may occur, but they are less common. The other mucosal sites which are affected are very uncommonly the lacrimal glands, eyelids, external ear canal, esophagus, larynx, the urinary bladder, and anal region can be affected. Now coming to lichen planopilaris. Lichen planopilaris presents as tiny red spiny follicular papules on the scalp or less often elsewhere on the body. Sometimes blistering can occur in the lesions. Destruction of the hair follicles leads to permanent bald patches characterized by sparse, lonely hairs. These permanently bald patches or lichen planopilaris will lead to cicatricial alopecia. Frontal fibrosing alopecia is a form of lichen planopilaris which affects only the anterior scalp, forehead, and eyebrows. So only this part, these regions are devoid of hair, but the other rest of the scalp, the hair is present. Now the other condition is Pseudopelade of Brock. It is a variant of LP without inflammation or scaling. Areas of scarring without hair slowly reappear, described as footprints in the snow. So now coming to nail lichen planus. Lichen planus affects one or more nails with or without skin involvement. There is a condition known as 20 nail dystrophy, that is all the nails are abnormal and nowhere else it's affected. Lichen planus thins the nail plate, which may become grooved or ridged. The nail may darken, thicken, or lift off the nail bed, leading to onycholysis, that is separation of nail plate from the bed. And sometimes the cuticle is destroyed and forms a scar, leading to pterygium formation, which is a very characteristic finding in case of nail lichen planus, which differentiates it from the other conditions affecting nails. The nails may shed or stop growing altogether, and they may rarely completely disappear, leading to anonychia, that is absence of nails. Now the other common condition which has become very common nowadays is lichen planus pigmentosus, which is also known as ashy dermatosis or erythema dyschromicum perstans. Here, the patient presents with continuous and progressive pigmentation of mostly the sun-exposed part of the skin. And they are generally asymptomatic, but many patients might complain of itching. So what the patient presents is with ill-defined oval grayish brown marks are present, which are very ill-defined and very diffuse, mostly starting from the face and progressing over the neck and chest, upper part of the chest, and then limbs, the upper limbs, and can arise in the sun-protected sites like the armpits also. There is no inflammatory phase. There is a direct deep hyperpigmentation of the skin is a direct presentation. It is a form of acquired dermal macular hyperpigmentation. It can be provoked by sun exposure. And these diffuse reticulate and diffuse patterns can be seen. It may rarely affect the lips, resulting in a patchy dark pigmentation of both upper as well as lower lips. And sometimes even the other chemicals or additive factors contributing to this conditions are hair color, uses of hair color containing chemicals. Then mustard oil can sometimes aggravate to this condition. And sometimes using perfume and deo sprays can result in aggravating this condition. And we advise the patient to use coconut oil or olive oil instead of mustard oil. And then using deo roll-on besides except and avoiding perfumes and deodorants can also be one solution in avoiding the progression of this condition. The condition is lichenoid drug eruption. It refers to a lichen planus-like rash caused by medications. And they are generally asymptomatic or itchy. Sometimes the presentation is pink, brown, or purple, flat, slightly scaly patches, which mostly arise on the trunk. The oral mucosa and other sites are also sometimes affected. Many drugs can rarely cause these eruptions, like gold, hydroxychloroquine, captopril, quinine, and thiazide diuretics can lead to photosensitive lichenoid drug eruption. And there are many other drugs also which I have not mentioned, but these are the common ones. And when a patient presents with hyperpigmentation, all these etiologies should also be ruled out. So what are the complications of lichen planus? Rarely long-standing erosive lichen planus can result in true squamous cell carcinoma, but very rarely. And it is most common in mouth, leading to oral cancers, or on the vulva, leading to vulvar or penile cancer. This should be suspected if there is any enlarging nodule or irregular outgrowth with ulcers and thickened edges. Then we should be more suspicious. If there is any change in the external appearance of the pre-existing lesions. It is more common in smokers and those with a history of cancer in the mucosal sites, and in those who carry sexually acquired and oncogenic HPVs, human papilloma viruses. Diagnosis is mostly clinical, based on the clinical features, and sometimes, not sometimes, many a times biopsy is done to confirm or to make the diagnosis and also to rule out the malignant conditions. The histopathological signs are of a lichenoid tissue reaction affecting the epidermis, and those are irregularly thickened epidermis, degenerative skin cells, liquefaction, degeneration of the basal layer of the epidermis, band of inflammatory cells just beneath the epidermis, leading to formation of civet bodies and colloid bodies, melanin pigment beneath the epidermis. So when we do a direct immunofluorescence staining, if available, we reveal deposits of immunoglobulins at the base of epidermis. And patch test sometimes is recommended for patients with oral lichen planus who have affection of the gums and who have amalgam fillings to assess for contact allergy to thimerosal. Treatment for lichen planus. Local treatments for symptomatic cutaneous or mucosal disease are potent topical steroids, topical calcineurin inhibitors, tacrolimus ointment, and pimecrolimus ointment creams. Topical retinoids, intralesional steroid injections are given mostly for hypertrophic lichen planus, where they're very resistant to treatment, and also sometimes given for oral lichen planus. Systemic treatment for widespread lichen planus or severe local disease often includes a 1 to 3 month course of oral prednisolone, while commencing one steroid-sparing agent from the following list, and the best preferred is acitretin, which is a oral retinoid. The other ones are hydroxychloroquine, methotrexate, azathioprine, or mycophenolate mofetil. So these are the immunosuppressives. And besides this, which is also commonly available in our local market, is steroid mouthwash or tablets are available, which can be used by the patients of oral lichen planus as a local therapy in the form of mouthwashes or gargles. Sometimes phototherapy is recommended in resistant cases. And in cases of oral lichen planus affecting the gums with contact allergy to mercury, it may resolve simply by replacing the fillings with a composite material instead. What is the outcome of lichen planus? Cutaneous lichen planus generally tends to clear within a couple of years in most people. It may clear within 18 months with recurrent episodes, in between frequent recurrent episodes. And mucosal lichen planus is more likely to persist for a decade or longer, and spontaneous recovery is unpredictable, and same should be explained to the patient. And lichen planus may recur even at a later date after a long pause. Scarring is generally permanent in the scalp, leading to balding or cicatricial alopecia. Then lichenoid drug eruptions generally clear up slowly when the responsible medication is diagnosed properly and withdrawn from the patient. Now let's see some of the pictures. So this is a typical picture of lichen planus affecting the hands, the ventral part of the hands as well as the forearms. You can see that there are multiple papules in a linear row, which has occurred as these lesions are very itchy and pruritic, and the patient goes on scratching, leading to appearance of multiple papules on a line. So this is a typical example of Cobnon's phenomena. You can see that the lesions are violaceous, scaly, mostly on the flexure aspects of the forearms and wrists. So these are the commonly affected sites, as well as the back is also one common site to look for. So this is a lichenoid eruption seen over the dorsal aspect of wrist. So the other picture is a picture of lichen planopilaris, where erythematous and diffusely involved hair follicles are seen, which are generally shed off and followed by fibrosis and cicatricial alopecia. Already multiple hair follicles are already lost, leading to multiple areas of alopecia. Now this picture shows pseudopelade of Brock, where a whole localized patch of cicatricial alopecia is seen in this patient. The other condition is, other picture shows typical case of oral LP, oral lichen planus, where the reticulate fine streaks of white lines are seen on the inner aspect of the lips in the buccal mucosa. Here the tongue is not shown to be affected, and generally lichen planus affects bilaterally. So bilateral examination and the palatal examination, the inner part of this lips should also be examined. So these all these three pictures represent lichen planus pigmentosus, where there is progressive pigmentation without any inflammation or without any pre-existing etiology in a normal patient with no other comorbidities. Mostly is seen over the face, the ears, upper aspect of the back, neck very clearly, and you can see that these lines are spared. So mostly the sun exposed parts are seen to be affected. And the same thing with the other lady. And so these two pictures show a case of lichen planus, and this is a typical pterygium formation. So when sometimes you can get such kind of pictures as a spotter, so you should be able to say that this is a case of this is a pterygium formation, which is seen in case of nail LP. So whenever we find a case with oral LP, oral lichen planus, or cutaneous lichen planus, the nails and the other mucosa should always be examined or at least be inquired about. And this is the case of lichen planus in a patient where all the nails are affected, gradual dystrophy leading to onychodystrophy. So thank you.